Good day, everyone, and actually good afternoon from here in Jordan. On behalf of AMFNet, I would like to warmly welcome all of you, and especially our speakers, to today's session under AMFNet's WEBi series. My name is Renda Saad, and I'm very pleased to be moderating today's webinar, which is titled Women's Mental Health: Addressing Challenges, Integrating Services, and Fostering Resilience. As we know, mental health is a core part of the overall well-being and plays a key role in health outcomes and family stability and community resilience. Today, we're focusing on women's mental health across the reproductive life course, an area that remains essential yet unfortunately often overlooked in our region, in the African region, and in multiple other regions. Before we begin, just a few quick housekeeping notes. Please feel free to share your questions in the Q&A box throughout the session. We will have a dedicated Q&A segment at the end, and we encourage active engagement from everyone. Actually, with that, it's really my pleasure to welcome our first speaker, Dr. Maysa Al-Nimr. Dr. Maysa is an associate professor of public health, occupational epidemiology, and head of the environmental and occupational health unit at the Institute of Community and Public Health at Birzeit University in Palestine. Her work focuses on the intersection of gender, health systems, and structural vulnerabilities, with particular emphasis on reproductive and mental health in fragile and crisis-affected settings. She has led and contributed to interdisciplinary research on integrating mental health into primary and reproductive health care, including school-based adolescent SRH and mental health services, strengthening referral systems, and the governance of women's health data. Dr. Maysa, the floor is yours.
Hello, everyone, and thank you for joining us today. I would like to begin with thanking AMFNet for this kind invitation and for organizing this important webinar on women's mental health, which is truly a timely and critical topic, particularly in our region, where women navigate complex social, economic, and health challenges that deeply shape their mental well-being. I would also like to acknowledge and appreciate my fellow speakers and colleagues contributing to this discussion today. It's a privilege to be part of this collective effort to advance dialogue and action in this field. So today I am very pleased to share some reflections from our work in Palestine, focusing on how we can move from fragmented services toward more integrated response and equitable approaches to reproductive mental health. I'll start with sharing my screen. Okay, so women in fragile and crisis-affected settings navigate reproductive care within fragmented systems, where mental health screening, referral, and follow-up remain inconsistent. Despite strong evidence linking reproductive and mental health outcomes, integration into maternal, family planning, and primary healthcare services is limited across the Eastern Mediterranean region. Drawing on implementation experience from Palestine, this presentation explores practical pathways for embedding mental health into reproductive care through task sharing, stepped care models, and strengthened referral systems in gender responsive governance reforms. It highlights scalable strategies for building resilient, integrated health systems that protect women's health and well-being across the reproductive life course. So mental health is not separate from reproductive health. It is a fundamental component of it. We know that perinatal depression and anxiety are common and they have significant consequences not only for women, but also for child development, family functioning, and long-term health outcomes. However, despite this strong evidence, services remain fragmented. In our work examining postpartum mental health, we consistently see that mental health concerns are under-detected, and even when identified, they are not systematically followed up. So the challenge, it is what I refer to as the integration gap, the disconnect between where women access care and where mental health support is actually provided. Women regularly access antenatal care, postnatal care, and family planning services, which are critical entry points. At the same time, mental health services exist, like counseling, psychosocial support, and specialized care, but the connection between these two systems is weak or absent. As a result, screening is inconsistent, referral pathways are unclear, and follow-up is often missing. This gap where many women are lost. So when we look at how this plays out in practice, we see several patterns. Mental health screening is not routinely embedded in antenatal or postnatal care. Referral systems are often informal or unclear, and there is rarely a feedback loop or to ensure the continuity of care. For example, in our work on adolescent health, particularly in school-based settings, we observed similar challenges. Even when students were identified as needing support, referral pathways were often fragmented or not functional. This highlights that this issue is systemic, not limited to one population group. So to understand why fragmentation persists, we need to look at this at the system level as a whole. So parts of the system, health system building blocks are also considered in this fragmentation. For example, governance structures are often fragmented across sectors, where each sector works in parallel. The workforce also may lack training on mental health integration and the basic screening for mental health issues. Financial mechanisms do not prioritize integration services, and importantly, health information systems often do not adequately capture mental health indicators. For example, in our research on women's health data governance, we found that mental health data is frequently incomplete or poorly integrated, which further limits planning and responses. In fragile settings like Palestine, these challenges are further intensified. We are dealing with ongoing political and economic instability, mobility restrictions, and a highly fragmented service delivery landscape involving multiple providers. At the same time, women are exposed to chronic stressors that significantly affect their mental well-being. In this context, integration is not simply a technical improvement, it becomes essential for ensuring continuity of care and system resilience. Still, there are opportunities for integration within the primary healthcare level, and this has been identified across different recent research projects that we have conducted in Palestine within different settings among adolescents and women. So across the different areas of our work, we see consistent patterns. For example, in adolescent health, we're in our work regarding related to adolescent sexual and reproductive health and mental health in the school system, we found gaps between identification and referral. While in maternal health, mental health concerns are often not systematically addressed within the routine care. And at the system level, regarding data systems do not adequately support this integration. So these findings reinforce that the integration gaps occur across the life course and across different entry points within the health system. Based on these insights, we can think about the integration through 4 key pillars. First, the systematic screening. embedding simple, routine mental health screening within reproductive health services. Second, task sharing, enabling nurses, midwives, and the primary healthcare providers to deliver basic psychosocial support. And third, functional referral pathways with clear protocols and feedback loops to ensure continuity of care. And fourth, the supporting governance, including policies, training systems, and accountability mechanisms that enable this integration. So let me briefly illustrate this with some examples from our implementation research. So in our adolescent SRH and mental health project, we are introducing a sustainable training program for educators on screening and early detection of mental health issues among adolescents and on the referral pathways. In addition to also introducing clear referral pathways and coordination mechanisms. In our work on maternal health, integration also of the screening into the routine healthcare within by provider training and system level support, like having the screening tools embedded within the primary healthcare system. And talking from a governance perspective, plans are to integrate mental health into health information systems, which is critical for monitoring and also improving and following up the services. So these examples show that the integration requires action at multiple levels, at the primary healthcare, the workforce level, and also the system level with the health information system included. So moving forward, there are several priority actions that we could think about, which include integrating mental health into the national maternal and reproductive health strategies and guidelines, standardizing the screening tools and protocols, strengthening the referral systems with the clear accountability, investing in workforce capacity building, and ensuring that health information systems capture relevant mental health indicators. These are practical and scalable steps that can support integration. So to conclude, integration is not about adding services. It is about redesigning the systems. Primary healthcare is a very good and a critical entry point. Talking about fragile settings, we require to think about context-sensitive and adaptive approaches, and ultimately, gender-responsive systems are essential for improving the outcomes. And at the end, I wanted to say that if we continue to treat mental health as a separate from reproductive health, we will continue to miss the women who need us the most. Thank you so much.
Thank you, Dr. Mesa, for this very insightful presentation and for your focus actually on the concept of integration and the tool of implementation science and how we can bring all of this together, especially if we're aiming for a system level change, which is something we at MFNet always call for to actually lead to a meaningful and impactful change. I have a bunch of questions which I'll keep till the end. For now, we're gonna move to our next wonderful speaker, Dr. Rania Abul Hassan. Dr. Rania is the Director of Member Association Support and Development at International Planned Parenthood Federation's Arab World Regional Office. She's in Tunis. She's a medical doctor and senior public health specialist with over 25 years of experience advancing the health, protection, and rights of women and girls in both humanitarian and development settings. She has worked extensively with the UN and international organizations across the Middle East, North Africa, and beyond, with expertise in sexual and reproductive health, mental health, and psychosocial support and gender-based violence. Dr. Rania, welcome.
Ahlan wa sahlan. Thank you very much for hosting for hosting me in this very important topic to be discussed at this very certain time, looking at what we are facing in the Middle East now and what are the challenges that have been posted to women and girls in these unfortunate circumstances. Um, I don't know if you can see my screen. Okay. So yeah, I don't know if everyone listening to us knows what's IPPF. IPPF is the International Planned Parenthood Federation. It's a federation of more than 160 organizations globally. This is local organization who are providing sexual reproductive health services scattered all over the world. And then the Middle East and the Arab world, we are looking after, a number from 22 to 24 partners of them scattered in the Arab world region. My presentation will be focusing on some of the lessons learned from the existing women health interventions in Sudan, Palestine, Yemen, Lebanon, and Syria. And in front of you is a collection of all of the communities that comes together for the annual meeting in Tunis to guard and to control their programs. So what we are looking at now is the region of the Arab world. And this region is very unique because we are having overlapping crisis, a crisis over crisis, displacement over displacement, a lot of economic collapse, and also a lot of humanitarian emergencies. Some of it also is with like a natural disaster, which is happening occurredly in the Middle East that like nobody have been looking at before because of the climate change, of course. So this Arab region hosts four of the top six countries globally, which is hosting IDPs. We are looking at 15 million IDPs across this region. 28 million women and girls require humanitarian assistance, in them 7.3 millions at the reproductive age. There is already an embedded factors in the community socially. There's an existing protection concerns when it comes to the harmful practices like female genital mutilation, which exists and goes beyond 87% in Egypt and Sudan. There is sexual minorities, which is facing increased risk and report criminalization and some restrictions like in Lebanon, there is honor killing still exists. We have also the utilization of rape as a weapon of war, which is exist in Sudan during this war. Now, also in our region, we have a shrinking civil space for the protection mechanism. So, like if we are looking at the global sphere and the commitments that made by the countries in the Arab world regarding women, peace, and security, you will find a very small number of countries who have been committed to that. The conflicts have led to destruction of the health infrastructure. So in some countries, you have a destruction of more than 80% of the health facilities, and there is no essential drugs or even there is a drain out of the personnel who are providing health services that have reduced the access to mental health services, the emergency obstetric care, and the response to gender-based violence and its consequences. This is a snippet from the performance of providing services in relation to sexual reproductive health in the Middle East or the Arab world. And you can see that there is a number beyond 4 million 4 million in the top 10 countries in the Arab world of services which are non-SRH services. Most of those non-SRH services, medicalized services, are related to mental health. So you can see the growth from 2023 to 24 and then some decline in 2025. And this is like a glimpse of what's happening in the region between the actors who are providing sexual reproductive health, but also have identified the very important lesson learned linking mental health to reproductive health. So Number one, integration with productive health and the protection. SRH and mental health linkages. There is an integration. The integration should be integral to the reproductive health services. The mental health and the poor mental health provision of services can disrupt the reproductive outcomes and vice versa. So, if we are looking at the trauma or the crisis zones, reproductive health problems, we cannot separate them. Menstrual irregularity, infertilities, miscarriage, unwanted pregnancies, most of all of these issues which is dealt by the reproductive health providers have an integrated part which is mental health issues. In the integration itself, we have learned that safety is first. And if we are going to integrate this and integrate gender-based violence prevention or safe space or legal aid, or we need to speak about safety of women and girls first, because that is the fundamental to provide any health services, either reproductive health, either mental health. There is a very big need, and which have been very obvious on the tailoring activities in the camps on co-designing of the services. Women movement or IDB movement with women can also be challenging for the designing of the setups for the provision of health services under humanitarian context. But it's very essential and very important to have a co-design with the women in the place to decide where should be the services at, because that also will take off or will lift off some of the stressors for women to access services. Second bunch of recommendations or lessons are related to the adolescents and the approaches to adolescent care. And that is because of the unique vulnerabilities due to the crisis. And because in our region, as we have spoken before, there is a lot of existing cultural values and cultural harm practices, which is linked to protection. So protection in some of the crisis zone have led families to cut or go under the surgery for, send their girls under the knife for FGM because of protection issues. It have also helped or have even also promoted those IDBs to help them to go and sell their girls, or what's called forced marriage. They force them to marriage from protection issue. They force them. All of this condition with the exercise of the sexual exploitation, forced pregnancies. All of this is a very big risk for our girls and our adolescents girls. And we are putting some emphasis here because we need to tailor in our humanitarian response the adolescent girl response, which can prevent. Because when we are speaking about adults who have been already passing through, we are speaking about mitigation measures to mitigate the consequences. But when we are speaking about young girls, adolescents girls, we are speaking from the prevention perspective, not to allow zero tolerance for those girls to go to that pathway. Those integration or this adolescent approach should be also based in the community support. Peer-to-peer support, life skills education, safe spaces. And this is why in the programs that IPPF is leading, comprehensive sexuality education and peer education is an essential part for all of the humanitarian response. All of the humanitarian programs should have that community-based support, looking at youth and adolescents into that to prevent them from going at risk. And risk means everything. From protection risk, security, safety, going to mental health, going to reproductive health. Then in the third area, we are speaking about the psychosocial support and the resilience of the communities. Most of the Arab world communities are very resilient. They have been there for a long time. They know better than the interference from outside what they need. Psychosocial support should be built into highlighting the resilience and maximizing the use of the shared experience in the community. Researchers have shown that survivors of sexual violence in the Middle East have prioritized practical support. They have been there a lot. They have been listening, psychosocial support, but unless we have an economic opportunities, until we have partnering support for education, for financial grants, for that goes side by side with the counseling that will maximize the outcome of the helpness. So we don't go the pathway into the mental health problems by the gender-based violence consequence or evidence. So then community-based care using local practitioners, trained community workers, and traditional caregivers increase the accessibility and reduce the stigma associated with seeking mental health services. And then for this part, there is also a very important part, which is fighting the stigma. Because the same way that we are speaking about the essentiality for women and girls to access reproductive health services, we need to speak about the essentiality and the importance of having psychosocial support and mental health early diagnosis. And that cannot be happening separately from the community. We need to embed that in the programs in the community as early as possible when we are going to respond to a crisis. That cannot be later on. Unfortunately, this is the case. Yeah, it's happening later on, but it shouldn't be this way. Especially that we are experienced region with humanitarian crisis frequently, and our people are already developing the resilience to it. The fourth area is to overcome the barriers of the care. And when I was listening to my colleague presentation before, she was speaking about the interruption of the referral pathways. There is, unfortunately, there is no study can show us how much organizations have spent to start up referral pathways. How many workshops have been conducted to speak about referral pathways and how the referral pathway should be working? But by the end of that exercise, the gatekeeper, the one who's presenting that referral pathway, have not been educated enough to help people navigate that pathway. The carers themselves, when they have not been cared enough, they can be a turning point and they will be the obstacle to utilizing the pathway. So we need to reduce the stigma between trying to do psychoeducation for everyone, for anyone this is not a luxury. This is a very essential part of the emergency literacy. We need to address also the cultural context, and that is the most difficult part of it, because some of the cultures may increase the trauma and may increase may jeopardize the mental health in the context because of some of the practices. Programs also should enhance the literacy and allow women to recognize symptoms, access service actively. The same way that we are spreading information about malnutrition, we need to speak about vital signs for women and girls to identify when they are stressed, when they are in need of help, and even to help others. And this will come now. So in the nexus building and in implementation in the stress setting, we need to have non-specialized delivery. shifting the task, which usually we do that in the obstetrics and gynecology, where we shift like some of the services from the medical professionals to the nurses. We need to now also to start shifting the task, because for the Middle East or for the Arab world region, most of the medical practitioners were non-specialized in um, non-specialized, or they were avoiding, I think, because of the big stigma, speaking about mental health and being involved in such issues. So training the community volunteers, the nurses, the non-specialized personnel into the ABC of the mental health support can help into building that nexus and trying to build the gap. There's also a very big fear from the withdrawal of the services when the conflict goes from hot to cold. And that's really happening. Like, for example, what's happening now in Yemen, because cases have been called now because there is a new eruption in Palestine, in Lebanon, in Iran, in other countries. So the interest have been less. It's a cold case now, but that means, is the interest of the donor still there to support the existing PSS services, or it have been shifted to other areas? That's a very big danger. Changing and being named cold crisis also has helped. And one of the very important areas our clinic are speaking about is the postpartum, because usually in the war zones, we had a lot of cases of postpartum depression, and a lot of suicidal statistics coming from some of the war zones. Either postpartum depression is caused by the outcome that linked to the being an outcome of rape, or also a case of the long stress that everyone is facing in the Middle East, in the Arab world. So finally, mental health interventions for women and girls of reproductive age in the crisis zone must move beyond traditional clinical approach to address the combined trauma, safety, and systematic gender inequalities. The lesson learned highlighted the effective programs are integrated by community-based survivor center, focusing on both of the immediate protection and the long-term resilience. Thank you, everyone.
Thank you, Dr. Arania. You've actually highlighted several key and important issues, whether it's safety comes first. I'm going to start using this statement, safety comes first. The specific context of women IDPs and the challenges that comes along with being an IDP, and of course the issue of the specificity of adolescent girls and how we should stop talking about mitigation measures when it comes to adolescent girls, and really moving towards the concept of preventive services and embedding this into an already resilient community, but unfortunately, as Dr. Maisa said, and not so resilient health system. So it's the resilience is within the communities and not the health system. So we'll talk more about this, but last but definitely not least, our third speaker, Mr. Dumsani Mamba. He is a mental health technical officer at Africa CDC within the Division of Disease Control and Prevention. He's a psychiatric nurse and public mental health expert with multiple years of experience advancing primary mental health care and policy advocacy. Mr. Dumsani is also the founding director of Iswatini Mental Wellness, an NGO focused on mental health awareness, education, and service provision. During COVID pandemic, he played a key role in delivering psychosocial support to both patients and healthcare workers. Mr. Mamba is recognized for pioneering innovative initiatives, including Eswatini's first telephonic mental health support platform, and for his strong commitment to expanding access to mental health services across the African region. Dimsani, the floor is yours.
Thank you very much, Aranda, and good afternoon, everyone. I think there's one thing I probably might have felt now is the pressure of speaking after Dr. Rania with so much experience and covering so much ground. I'll speak on the context of Africa CDC and looking at the African context, and also further appreciating the two amazing presentations that have been done before me, which speak directly to women's mental health. And there is so much takeaway I've picked from the two presentations. And I'll highlight some of those as I move on with my presentation. Can we get the next slide, please? So on this particular slide, I want us to look at the mental health aspect within the African continent and African context on the challenges that have been presented. I think some of them have been presented earlier by my other fellow speakers. But one of the main things I would speak about, it's number one, the prevalence of mental health disorders. Within the African continent, we have a huge problem on mental health, which is a problem of neglect and less prioritization, which can be seen through how we have so much gap on mental health and mental health service provision. With about 20% of women in Africa experience mental health disorders, and these include depression, anxiety, which is often exacerbated by the socio-economic factors and cultural stigma. And one would really emphasize on the issue of cultural stigma because we know the African continent is rich with culture, and we still very much grounded on culture, and culture plays a big role in the visibility and the acceptance and reception of mental health services, and also the clinical screening and diagnosis of mental health conditions at an early stage. So when we're looking at the second problem is the issue around maternal mental health. And this is very much unique to women's mental health because most of the time when we're looking at mental health, we look at it in the broader spectrum. But when it comes to women, there are very specific things which include maternal mental health. And one of the key things that we have noted is postpartum depression affects about 10 to 20% of women after childbirth in Africa. And these are factors that are included by so many others, one being lack of support, the socio-economic stressors around giving birth, and majority of the trends we have seen that there is actually a problem of single parenting within the continent. You have lots of young women giving birth, but the other partner is probably hardly found when it comes to after delivery. And these are some of the other challenges that we actually have seen. And also, again, the cultural expectations. There is so much involved with regards to culture and a woman giving birth within the African context, which most of it actually is a risk factor that draws women much more closer to being prevalent to mental health disorders. And the third challenge is the accessibility to mental health services. Within the continent, we have like the main problem, access to mental health services in general. And this actually becomes more worse when it's on the woman's side because it is a problem that has so many things underlying within it. For women, you probably might not have the time to go to the clinic because of socio-economic factors. You might have not the time because of primarily the stigma again, lack of resources, and the insufficient of health services and infrastructure. In most instances, you would find that you'll have to walk so much long distances to get to a health facility. For men, that's probably something that they can overcome because of their physical abilities. But now we are speaking about a young girl, a young woman who probably might not be able to do that. Or in the event they are strong enough to do that, safety around that particular long distance that they have to walk is also another challenge. And also beyond that, again, cultural beliefs. We within the African continent, we've got so much belief in culture, and most of these are the hindrance towards women accessing mental health services. And in some instances, you going to the hospital or to the clinical facility to look for that particular service, there's so many things that are attached to you as a person in terms of you being identified as a weak person, a person who can't hold your own. And most of the time, we normally would label our women as superhumans, people who are able to multitask, which means you can deal with the problem, handle the family, handle the job, handle the neighbors, handle the whole community. So if you are not able to do that as a woman, then it's a challenge that makes you look like you are not woman enough. You are not able to do other things that the other women do. For some reason, I feel if you look at some of the cultural influence on women accessing mental health services, the hindrance is women wanting to be octopus. I think we probably might all know what an octopus is and how its ability to be able to do so many things at once. And if you are not able to do that, you feel like I need to go out there and it's difficult to go and access these services. The last bit is in most cases where the mental health services are available, they're expensive. That comes in the economical instability and poverty. That also is another challenge. You will find there are those who have the facilities, the services nearby. The problem is, are these services affordable? Yes, I can go to the clinic. They tell me, oh, you need this particular medication. For you to be able to be being assisted, you need to pay this much. The money is nowhere to be found. So the challenges around the economic side of things is also another hindrance towards accessing the mental health services. And then we've got the big one, the gaps in policies and legislation. Most of our African countries are using archaic mental health laws. And this is a hindrance in terms of advocating and trying to do advancing of mental health integration into primary health care, mental health integration into community-based care, and the provision of mental health services within the communities, even at tertiary level. You find that with member states, the budgets are not available and they are not channeled towards mental health. Why? Because there is a missing tool, which is the legislation. Without the legislation, it's very much pretty difficult to do advocacy on. We need more services on these. We need services that are going to be tailored specifically for the support of women, services that are going to be accessible for women. And I like what Dr. Rania said when she spoke about mitigation and prevention. These laws and policies are all about trying to improve the prevention. Because with mitigation, that's within the adult space where we are now trying to do damage control. But the best to do it is to have the policies that are going to protect and prevent our young girls and adolescents being exposed to the lack of services, being exposed to the stigma around the provision of these services, being exposed to the non-accessibility of the services because of cultural reasons, which are not supposed to be a hindrance, but also a way of living and supporting how we live within our communities. Next slide, please. So this one, I will speak on the issue around mitigation. I think from the presentation by Dr. Rani, I should say mitigation stroke prevention, which is also a learning on my end. So when we're looking at all the challenges I've presented earlier, if we look at addressing women's mental health in Africa, it requires a multifaceted approach that includes improving the general access to mental health services, reducing stigma, the implementation of gender-sensitive policies, as I've spoken about. And with us focusing in all of these, the outcome on all of that will actually have a ripple effect on some of the areas I'm going to speak about. The improved access to mental health services. We need to improve access to mental health services. How do we do that? We need to increase availability, expand the access to where the services are. We need to also bridge the treatment gap by training more professionals and also integrating mental health into primary health care within the community setup. And one way of doing this is actually doing it through the community-based services. Let us have more people trained within communities to try and strengthen community mental health programs, to have people that are non-practitioners being able to provide the services. We're talking of psychological first aid. We're talking of task shifting here, where we have the community-based community health workers being able to do basic screening of mental health conditions and also being able to use in community structures for referrals for tertiary care and other related services that may be required. Number two, we need to have culturally sensitive and community engagement. Cultural sensitivity speaks in terms of us being able to come up with interventions that are Afrocentric. What do I mean by that? These are interventions that will be integrative, receptive, and accommodative to the different cultures that we have, different religions. And these, by doing so, we are actually moving towards a space where we are able to get all the different local stakeholders, which are the community leaders, the traditional healers, the spiritual leaders, to promote the acceptance of mental health services, because most of the time we have the hindrance between the local structures where one would say, no, this is a foreign concept, you cannot do this. But if this information comes through the spiritual leaders, it's easy to consume for the people that are within this space. And one thing I have realized and seen is most of the time when we speak about spiritual leaders and traditional leaders, the entry point and the easiest entry point when you want to make a change, you speak to them, and then women are a majority in most of these spaces. So if you want to have these upscaled and totally acceptable, you need to speak to these different stakeholders, which will then have a direct link to the women that would want to build their capacity and build the proper structures and service provision for. And the other trick around it is, within the cultural setting, men will normally be the dominant force, but men would normally listen to certain structures, be it the traditional leaders, be it the spiritual leaders. So these are going to be stakeholders allowing and enabling the conviction of men to allow their women to take these services without the hindrance of putting cultural barriers. And also the provision of the resources, because with the poverty lines and all the socioeconomic factors, most of the time you'll find it's the men that is doing most of the work within some of these spaces in the cultural and remote spaces. So in terms of winning the men on board to be able to support, you win the men to support the women, and you get the women to understand the challenges so they can also do a convincing role to their men. And one nice thing about the role of women in all of these, everyone is born of a woman. So one way or the other, any man out there has a woman they listen to, and they'll be willing to listen to that particular woman. So it includes the intervention of speaking to certain key stakeholders. And the other aspect is the tailoring of the interventions. We need to have interventions that are very considerate of cultural practices. But in that being said, there are certain cultural practices that we need to phase out because they are not helping in any way. And in order for us to do that, it also comes in the stakeholder engagement. Speak to the traditional structures, the people that are gatekeepers of some of these interventions that we do not want to have in place. So the other component that we're probably bringing in as a mitigation or a preventive approach is the holistic approach to health. Mental health integration into primary health care. We can never really overemphasize the importance of these, because with all of that being done, mental health being integrated, we are saying whenever you are going to seek services for whatever service within the health structures, you should be able to have mental health services available for you to tap into without having to go elsewhere or without having to do a separate appointment. One of the big problems we have, even when we improve the access to mental health services, you normally find mental health services are isolated. And that is not the right approach. But if we put everything together, it reduces the stigma, it saves on time, it saves on resources, and it also makes the services look attractive. You're coming in for your maternal, should I say, your maternal health care as a woman. You do your prenatal care. As you are doing all of that, you are being assessed for mental health services as well. You get all of these in one package. It makes it nice and easy. It saves time. You then don't have to be away from so many of your responsibilities as a woman who is expected to be an octopus one way or the other. So the other bit is around the mental health advocacy and legislation, which speaks to policy reforms. Africa CDC has been doing a very intentional job to try and advocate for mental health law reforms, which is one of the big mandates we have, because we have appreciated that without the legislation, there is minimal we can be able to use as a tool to convince the member state governments to take mental health as a priority. And in us being able to do this, we need to make sure that there is that element of saying, we are saying do this because there is a strategy that the country has adopted to speak to mental health. We are saying integrate mental health services because there is a policy that is backing our claims. Or we are saying there should be an integration of mental health into different workspace policies because the country has a law that protects mental health rights for people within country. And in particular, when we speak about everyone, women are part of the special key populations when we're talking about mental health legislation, looking at the Human Rights Charter as well. Next slide, please. So I've spoken about Africa CDC's different approach. These I'll just touch through because I wanted to have these as evidence to show that actually there is so much going on with what Africa CDC is doing. We have a strategic approach, which is actually very inclusive. The first one is we're currently implementing the strategy on NCDs, injuries, and mental health, which has these priorities indicated on screen. But the interesting thing about the strategic priorities of the NCDs, injuries, and mental health strategy, it actually aligns to strategic priority number 1 of the Africa CDC strategy, which speaks about strengthening the integration of health systems to prevent and control high burden diseases. And mental health is one of those. So in us being able to say we are having a strategy to implement at division level, we are also informed by the strategy that member states have validated at Africa CDC level. And in addition to that, on the next slide, we also have another strategy that I think is very important on the protection and trying to improve women's mental health. Please, can you check the next slide, please? This is a strategy on reproductive health, which again, that strategy on its own fits into priority number 1 of Africa CDC strategy. So in addition to these strategies that we have and that are put in place, it's a clear commitment from Africa CDC that we are out here to protect women, adolescents, and making sure that the health of women, as the majority people within the population we have in the continent, and as also a majority of the people who play a critical role in the development of the continent, we need to have these strategies in place and also have these different areas of health that touch on women being protected and also having strategic priorities that are aligned. Because if you look at the priorities from the strategy of NCDs to the one for mental health, you'll see there is so much look-alike on issues around local manufacturing, on issues around pool procurement of drugs, on issues around the targets and protecting human rights, particularly for women, and also issues around sustainable financing. These are very critical components that we need to look into. Can we move to the next slide, please? So I've spoken much about this, but I just want to highlight some of the key interventions towards advancing mental health in which Africa CDC is working on. One of the key things right in the middle of what you probably see on my screen is the integration of mental health into primary health care. That's the genesis of everything. If we are able to do that, and Africa CDC is actually championing that agenda, there's one of the new lines of work that we are working on. For those who have interest, you can check it out. We have what we call the Lusaka agenda, which is also aligned to championing the integration of mental health into primary health care. And then we have these other different areas. There's research and evidence generation. Dr. Rania spoke about the importance of having evidence. When we speak of resilience, resilience cannot be known and tested if there is no research backing it up. So we have the research, we have all of these different components, because in order for you to make any intervention, it has to be an evidence-based intervention. So we also have a very strong research agenda for the purposes of getting more evidence. And one of the key weaknesses we had coming from the past with African mental health is we do not have the data. We have everything. We can put all the claims and say, these are the challenges we have. All the challenges I spoke about in the past would say all of these things, but the question is, can you prove it's there? Problem is our surveillance systems were weak. Our data collection tools were not really functional. So that made it very difficult to back the claims of what was happening on ground with the numbers in order for us to be able to say, this is how much we are losing. It's only recent we started doing investment cases, which correlates to the socio-economic side of it. Finance ministers don't listen to the number of patients. They listen to the amount of money they have lost from people not being able to attend work. So we need the data that will back that up. And then we also have another component where we are doing workforce development. We will be very honest about the gaps we have when it comes to workforce in the continent. And one of the key components, we have intentionally taken interventions to improve and strengthen the workforce within the continent. We have what we call the Mental Health Leadership Program, which is aimed at building capacity within the continent, capacity of so many people at different levels of intervention. We have the highest level, which is at policy and legislation level through the Kofi Annan Fellowship. We have the second level, which speaks to field epidemiology and surveillance, which is the FETP program. And then we have the third level, which is on advocacy and leadership, where we are building capacity of people to be able to be leaders on mental health, because we need more people who will champion the cause of mental health, who will speak with strong conviction from a place of being informed and try and influence the uptake of mental health services, fight the stigma, try to make mental health accessible to communities. And the last bit is on community development as well and CSO coordination. And then we also have activities around mental health and advocacy, awareness, mental health legislation and policy reforms. And I think this last one, Dr. Rania spoke about it, the integration of mental health psychosocial support into emergency preparedness and response. There has been so much neglect on that end. And we as a continent, and I would say we are very prone to humanitarian crisis, be it conflict, be it natural disasters, there is always something happening somewhere. And most of the time, when we speak of mental health, we normally would think, no, we'll deal with that after. But there is the immediate impact. When we're doing MHPSS integration, it should be pre, during, and post. And most of the time, we are very active on the during, and we forget the pre, which is when we are trying to wrap things around. But the most other critical part is the pre. When we are at peacetime, what are we doing to improve the health systems so that when we encounter such a challenge, we are able to respond in the most quickest way? We should be less reactive, but more proactive. And the only way to be proactive is putting systems in place that are going to be sustainable beyond a single emergency or a single humanitarian crisis. Next slide, please. So I've spoken about these. These are some of the areas of work which Africa CDC has been working on as evidence to the advancement of the interventions I've spoken about. So we're going to take very little time on these ones. As one of the interventions on integrating mental health into emergency response is we have conducted 5 regional trainings across the 5 regions of the continent. And the Northern Africa platforms of the Mediterranean region, we have done all of those to bring together the mental health focal persons in country and the emergency response focal people to say, can we have a conversation on the same table? How do we integrate mental health into what you do during response? And one interesting thing that we picked in those conversations was, in some countries, you would find mental health focal person doesn't even know who is the emergency response focal person, because everyone is working in silos. But for those who knew each other, it was a battle of you want to come into the table to slow us down. Because the assumption again is mental health integration will slow the response down, without actually understanding that if you have MHPSS integrated in the public health interventions or clinical interventions, you stand a better chance of dealing with the challenges much more easier and quicker. Any intervention with MHPSS included in it yields more results quicker and more impactful results in a very short space of time. So these are some of the things we have done. And in addition to that, we also have integrated mental health into the Africa Union Volunteer Health Corps, which is a specialized team of responders. Previously, we didn't have responders that had the background in mental health. And now we have recruited about 30 who are now specialized on MHPSS, so that when we deploy, we don't only deploy the other sectors, but in the teams that we deploy to respond in whatever emergency or crisis that is in one of the member states, we have someone with a specialty on MHPSS. So those are some of the interventions that we have done. Next slide, please. As I have indicated, we said with the interventions on trying to improve mental health, it can never be within the health sector alone. And in that being the case, we have actually been championing for the last 2 years to try and have a multi-sectorial engagement, coordination, and action mechanism or framework that will be endorsed by the heads of states within the continent to advance and engage all the different sectors, to have them agree that most of the mental health risk factors are not within health. They are from all the different sectors. So in order for us to be able to mitigate and prevent we need to get everyone on board. So we have a framework that recently, in the recent assembly of the Africa Union Head of States, we have a document that we have developed, which is the MECA framework, which was actually adopted by the AU heads of state as a document and a framework for the continent, which I think is a plus and a big win, because now we have a tool for advocacy when we're speaking about multi-sectorial engagement, that we need to have everyone on board. We need to have finance, agriculture, natural resources, peace and security as part of the conversation when we're speaking about the prevention of mental illnesses and the promotion of positive mental health. And as I said, women are always at the center of these because they are part of the key populations. Next slide, please. So on the next slide, these are just some articles that I wanted to show, and as part of evidence on the research and evidence generation that we have actually been working on, things that are lessons learned from some responses that we have done. And in addition to that, how best we actually been moving, and we really want to champion the agenda of research so that we can have evidence backing us up on the claims that we are making and on the interventions that we are making. Next slide, please. Yes, again, with this is just to show some of the milestones. I indicated that we are actually supporting different member states on the mental health legislation reforms. Not so long ago, we were supporting Nigeria to advocate for the passing of the mental health bill into law, which was successfully done in 2023. So Nigeria has the most latest mental health law in the continent. And currently, we are actually supporting Sierra Leone, which is pushing with a bill in parliament that has had the multi-sectorial engagement take place. The bill is at the almost highest stage. And in addition to Sierra Leone, we also have the Gambia, which is in the same process. We have Burkina Faso, which is working on the same process. We've got the likes of Kenya, who are working on mental health reform, on suicide laws. So these are some of the areas in which we have been pushing and championing the reforms of mental health within the continent, particularly on legislation. And these are legislation that will then give a platform to change the policies, to change the strategy, to go to the level whereby we are integrating mental health into primary healthcare. Next slide, please. I think this probably the next slide will be the last one, which I've spoken about, which is the Mental Health Leadership Program, which is a program that speaks to mental health workforce development. And this program, like I have indicated, it is in 4 tiers. And the interesting part is we have been trying to be very intentional about the inclusion of women in this particular program. And if we go to the next slide, I'll probably be able to show some of the interventions that we have that are championed by women within the continent. And
Mr.
next slide, please.
Zintani, we have 2 minutes.
Okay,
to go to
it's
the
one,
Q&A
I think.
session, yeah.
All right, not a problem. I think it's one more slide left. So these are some of the pictures of women who have actually been going through the mental health leadership program, which the third pillar, which is the short courses on mental health leadership and advocacy. We have about 158 women enrolled out of about 200 that have taken the course. So majority of the graduates from the short courses have been women. And that is an intentional thing from the Africa CDC viewpoint, because we have clear understanding that women actually are the driving force in trying to make the change within the community. And hence, it is very intentional to build capacity of these women. As you can see from one of the slides, we've got a lady who provides mental health services from within a salon. Instead of only being a beauty place, it's a place where people come to do their hair and they also get mental health services at community level. We've got women who are championing mental health advocacy through their lived experience. Others are CEOs of hospitals where they are championing the integration of mental health into primary health care. So these are some of examples on what women are doing in different spaces. And these are women that have been capacitated to build capacity, to build community awareness, to make sure the integration of mental health is effectively done and it takes place from all different sectors of life. And I think this is probably the last slide. And in closing, that's the definite last one on high-level advocacy and communication. We are championing the agenda of making sure that mental health is not left behind in anything that we engage on. From Africa CDC, mental health is always a part of the activities that we of the integrations that we come with. So I think that's the last slide. And thank you very much for the opportunity to share and also share our reflections on the work that we are doing as Africa CDC. And we strongly believe that women remain at the center of any successful intervention. And by protecting and promoting women's mental health, we stand a better chance to advance mental health within the community and in the global space at large. Thank you very much. And back to you, Randa.
Thank you so much, Namsani. You made me smile when you said women are octopuses. I do feel like that so many times during the week. And I thank you for the very rich presentation and for the immense work that Africa CDC has been doing. A key point that you highlighted, which is mental health risk factors are coming from outside of the health. We need to not only focus on the health minister, but to also focus on the finance minister, because financial stability actually is a key pillar of system resilience. Let's go directly to the questions. We have a couple of questions in the chat. The first question that we have is for Dr. Maisa. It's from Dr. Mahendra Sheth, and she's asking, in your opinion, Dr. Maisa, should all healthcare workers be trained to recognize signs of mental health? So the question is talking more about screening. This will reduce the gap between reproductive health and mental health, especially if it is incorporated at primary health care. Most workers are not trained to recognize the signs. I just also want to add to this question, if we improve screening, how can we actually ensure that good screening will lead to meaningful follow-up? They might be able to screen, but are we going to be able to provide the services at treatment, management, preventative services at primary health care? The floor is yours.
Thank you. Thank you for the question. It's really important, and I agree with you actually that the training component should not only be at the primary healthcare level, it should be like a basic competency to recognize mental health conditions among different healthcare providers. But my focus was on primary healthcare workers as a kind of a strategic entry point. And not the only target group, of course, because especially for women's health and where women actually reach services. So primary health care could be like one of the main first point of contact for most individuals, like especially women, and also it includes highly population coverage. It will help a lot in the early detection process. So that's why there is a main focus on primary healthcare workers. But of course, as the colleagues emphasized, we should have basic knowledge among different healthcare providers, and we should have also basic knowledge among other providers. Like in our research, we have been focusing on educating or training teachers at schools to have basic knowledge on mental health, like early signs of mental health issues among adolescents, which will help also for in early detection and to prevent future problems among them. So the training and capacity building could happen at any stage or at any level, but it depends on the focus and what we exactly want to do. Related to your part that added Dr. Randa, related to the screening component, I agree with you, because sometimes we will have the screening and we could have the referral as well, but at the end we lose the last component, and we are not able actually to follow up if the service has been provided or not. And that's why we always think about the problem at the system level, because we should have this component throughout the system. So we should have also the follow-up loop, the exchange loop, and everything. Because, for example, also in our research on adolescents, we found out that there is a referral system from the school to the mental health services, but then the students will be referred, and then nobody knows what will happen to them. The school doesn't even have the information about if the students have reached the clinic, if they really got the service or not. So we still have this problem that should be addressed as well.
Thank you, Dr. Maisa. The next question is for Dr. Rania. We know what should be done, but can you give an example of a location or place where integration of sexual and reproductive health and mental health is actually taking place, and how is it being done?
So not one or two. The IPPF approach using the MISP, the Minimum Initial Service Package, have been linking always our intervention to psychosocial support and mental health support for the communities that we are working in. So let me speak. In Palestine, in Sudan, in Yemen, Palestine, Sudan, Yemen, Syria, even with the disaster response, we were going for the earthquake in Morocco. What we do and what the member associate of IPPF will do is to combine a mobile team. The mobile health services, which goes directly to the affected area, have an essential component of psychosocial support workers and community mobilizers. So the first move after identifying the location which the mobile team will be based is to look at the community partners and start having community mobilizers to gather them around to utilize the services, but also to give awareness session and to start having discussions and focusing, youth groups and, adolescent youth groups to support them with educational materials and to move the communities towards this. So from IPPF perspective, it was already integrated in everything, and we do have a very special funding opportunities for crisis zone countries where it is focusing not only in SRH, but there is also this permanent element of having the mental health and the PSS psychosocial support. One of the in Palestine, and I will put that as one of our achievement with the Palestinian family planning association is they are pioneers and identified by the GBV subcluster globally to provide the life support for GBV survivors. So they have been excellent in providing psychosocial support and also supporting survivors of gender-based violence, applying the life approach. In Syria, in Sudan, and in Yemen, we are still the PSS support workers, or support staff. They are working applying the psychological first aid, the PFA, in some aspect, because some of them are very trained nurses and trained in psychological basis. And in countries like in Pakistan or in Bahrain now, we are trying to start working with our PSS to provide the life approach to that. There is materials which we have been working with WHO. We have been translating it in the central office here, and we disperse those materials in Arabic and trained a bunch of TOTs in the Middle East to try to apply that.
Thank you, Dr. Arania. I'm going to jump to a question for Mr. Damsani, and it's with regards to the FETPs. Do any countries in the region, and here I'm assuming they're asking about the African region, have FETPs that focus on mental health?
Thank you very much for the question. And I think it's one of the successes that we are able to now speak about comfortably, that within the mental health leadership program under Pillar 2, which is Field Epidemiology Training Program, where we have intentionally integrated mental health as a module within the FETP existing program to make sure that as we are training epidemiologists, we do not only train epidemiologists that will understand the disease outbreak, but also those who will have an understanding of mental health. The reason why we do not have a specific mental health FETP program is because we do not want to preach to the repented. We want to get those who are actually outside of the mental health space to also appreciate mental health. And in the process, we get those with mental health background to be trained as epidemiologists as well. So it's a win-win situation in both fronts. And in terms of the catchment, I would say the intention is to cover the whole continent, but currently we have an FETP program that is taking place in Cote d'Ivoire, which specifically looks at the French-speaking component of West Africa. We also have another one that is taking place in Ghana, which focuses on the Anglophone side of West Africa. The one in Cote d'Ivoire actually is in sync with another one in DRC, which takes place for Central Africa. And then East Africa, we have a base in Ethiopia, where we have these stations have actually people coming from the different member states around that country or within the region to take the course. And this is happening in two fronts. We do it at advanced level, which is the master's level of epidemiology. And then we're also doing it at intermediate level, which is the 9 months program. And we also do have a segment for North African region, which covers the whole of North Africa and including the Horn of Africa as well, the likes of Somalia, Eritrea, Sudan, South Sudan, who are also doing the two component, advanced and intermediate. And recently, actually, we have expanded to some member states within the Southern Africa region. But the approach with that is the frontline type of FETP. So we've got like 3 segments of FETP programs. The frontline focuses mostly on NCDs, but with a component of mental health. And then advanced and intermediate is an integration of mental health into FETP programs. So the long and short answer will be we are implementing, and the exciting part is for North Africa, we are implementing with the support of MFINET, who are very, very strong on FETP, and we have actually initiated the trainings for the intermediate level. The Arab Republic of Egypt will be hosting, and then for the advanced level of FETP, it will be hosted by the Kingdom of Morocco, bringing the different member states within the region coming through one of these 2 respective countries for capacity building. And I should say it's one of the biggest successes we have done in terms of integrating mental health. And it's a whole new program. And we are looking at expanding and making sure it reaches the furthest part. And the return in investment will be seeing the change and the integration of mental health and improved data when it comes to surveillance of mental health within the respective member states.
Thank you, Mr. Damsani. We have a question, and I think this is a question for all our speakers, which is we keep talking about integration, but how realistic is that when hospitals themselves are being targeted in many countries in the region now? And are we now designing mental health programs for stable systems that no longer exists in many of the countries? So that's a difficult question.
I'll go first, and
Yes, please.
I hope I'll get support from my other colleagues. I think the idea behind the integration of mental health is not to create something new. And I think from the presentations that we have actually done, there is one most common thing that we've spoken about is the integration of mental health services into a full cycle of the pre, which is before the humanitarian crisis, the during, which is most of the time we find ourselves in, where instead of only having mental health services available in hospitals, available in clinics, which most of the time are high level or tertiary level of service availability, we integrate mental health across the different layers of service provision. We start from the clinics, the hospitals, hospitals and we go as far as the community, which makes it now in response when you're having a crisis, you can have people that are going to provide psychological first aid in the community. If it's a settlement camp, we have people providing the services within the settlement camp, which will not really require a building that, oh, there's a hospital here, you need to go there. The services should be, I would say, fluid in the sense that we should have people that are within the communities who can provide the services across the different situations we find ourselves in. But in a more stable environment where we now say the services have to be accessed in a facility, this is now when we're speaking about systems, the data capturing, where we say integration. You do not come to a hospital and leave without your data being captured for mental health services. You go in one place, everything is centralized. You go in here, the following day, you go somewhere else. You don't need to be asked how it was last time because it's within the data system. That is in a much more stable environment. But in a less stable environment, the services have to be fluid and they should be provided by people that are within the different situations and circumstances, but do not compromise the quality. So this is where we're doing the task shifting and task sharing. We move away from centralized mental health services in a referral hospital, but we can have them across all different sites, across the different facilities. Where you find reproductive health services, you should get mental health services. Where you go for your diabetic condition or services, you should be able to get mental health services within the same space, be it in a camp, be it in a community, and to some extent, even in the park, if we are that much fluid and situation calls for. So I think that would be my immediate response to the integration component, which I want to believe it's very realistic, particularly because we are, as humans, we are very social beings. And within the sociality of humans, we also have what I would say communities. Within the communities we are in, if we embed the expertise of mental health service provision, then we stand a better chance of services being available even in times of crisis. I'll hand over to my other esteemed colleagues to contribute and add more flavor into the integration aspect.
Yeah, okay. So I can go next and yeah, like I really like what all the points that you raised, but I want to add also the dimension of the time. Not also not only speaking about like building nexus because it should work from all like from humanitarian building nexus going to development, from development going to nexus being again humanitarian. So I'm trying to think loudly of the very important factor of involving youth and adolescents into this conversation. Because if we want to have like a hammering approach, a multi-sectorial approach, like a prevention approach, we should start from these young generations because they are the one who's going to lead the circle. And I think as much as we invest in news literacy, as much as we invest into linking comprehensive sexuality education with peer education, with whatever education that we want to insert in our youth programming and adolescents programming, that will help us on the long run to help into the tailoring the program, tailoring the response, having the support, having no, like in the humanitarian context where those adolescents, they have the information, they can be the one who's educating the communities, they can be the one who's running the PSS support, like in like as a worst case scenario, if you don't have, like clinical personnel to go around. And yeah, and I think part of it also is to tackle the issues, the cultural issues. Um, of long-standing, or long misunderstanding of the mental health disorders and the science and the symptoms have always created a very big obstacle for communities to understand. And I think, like building on that, we can also, like go and navigate how we can do better into responding to, like women, girls, mental health. Yeah, I will leave it now to myself to add.
Thank you so much. I think not much left for me to add. I agree with my colleagues. I strongly agree that but I also want to focus on the issue related to the when we talk about integration in fragile contexts and in pre-existing fragmented systems. We will never look at it as a stable thing. It should be flexible, it should be adaptive, and it should be also it should include the different components. Not only providers, we should have community engagement, community outreach teams, as my colleague said, the task shifting approaches, mobile clinics, the humanitarian response, emergency services, everything could have the integration of mental health within it. Thank you.
Thank you, Dr. Mesa and Dr. Ania. So all of our speakers today talked about task shifting or non-specialist delivery and task sharing. So within fragmented systems, within humanitarian settings, what are some considerations that we need to think of when we are training these non-specialists in mental health? Again, open to all three speakers.
I can jump here. So like there is out of consideration and red lights, when it comes to the training of the non-professionals and for me, like when I hear training of non-professionals or community volunteers, my heart jumps. Like I cannot understand this is being happy or being like afraid of what should be the consequences. A very small story, funny story that happened, I think, in 2010 when we were starting the response in Libya. And some of the community volunteers were running around trying to do psychosocial support and looking for survivors of sexual violence. That have jeopardized, the whole mobile teams. In 2011, when we started the responses in Libya, because of the the empowerment that have been given to those volunteers, they went running around speaking about sexual violence, without ensuring that they are discreet enough to provide services and to provide support. The other thing that sometimes, because as we said, safety first, in this training, so we say first, safety first, safety of the provider themselves. We need to equip them how to like help themselves, because even listening to stressful people can bring you stress, and caring of yourself is caring for the survivor. So you need to be able and you need to have the tools to take care of yourself so you can give and provide a good care and a quality care for the people. Then the other thing, which is at the end of each crisis, when everyone is running around, the trained staff volunteers, they will be becoming a collective, a collecting data tools. So the quality will be emptied by the repeated repetition of what they are doing in daily basis. And then from them, it will be a collection of data. So you will have a flow of data coming without a quality. If you're ensuring the quality without a quality, this is why the training itself, it should be backed with follow-up, with online, with on-job training and on evaluation and monitoring. These are my 2 points. Leave it to
Actually, we only have 3 minutes. So if any of the speakers have a quick final thought before we conclude this very rich discussion. If not, then allow me to thank you, Dr. Maisa, Dr. Rania, Mr. Dumsani. This has been a very thought-provoking discussion. Mental health is a key component, whether in a stable health system, fragmented health system, but it's also very important even in a crisis ridden system. Thank you for being part of this conversation, and I hope everyone stays tuned for more webinars from MFNet. And until the next time, thank you so much, and have a lovely rest of the day. Bye bye.